And with that, we go to the last session from today, which is a panel discussion. And I think it's a very important session, probably the most important session for today. And that is, what are the complications which we see in transplants in thalassemia major. And I think we're all aware that there are some unique complications which we come across in thalassemia transplantation. I think Dr. Gaurav is going to be doing that. Dr. Gaurav is a clinical lead and senior consultant pediatric hematology oncology at Apollo Hospitals in Delhi. And we have a very esteemed faculty today. Our teacher, some of us on the panel, Dr. S.P. Yadav, who is the director of pediatric hematology oncology at the Medanta, Delhi. Dr. Ruchira Misra, who is a senior consultant at SRCC and Narayana Health Hospital in Mumbai. We have Dr. Anupam Chakrapani, who is a senior consultant hematology at Apollo, Calcutta. We have got Dr. Ganesh, who is a friend, a senior consultant head of hematology from Yashoda Hospitals in Hyderabad, and Dr. Santanu Sen, a senior consultant head of pediatric hematology oncology from Kokula Bank in Mumbai. So a very esteemed faculty and great experts in the field. Gaurav is going to take us through some of these questions which are really relevant in thalassemia transplants. Over to you, Gaurav.
So, as Sunil and Satyendra has very nicely, they've highlighted what progress has been made in transplants for thalassemia. Along with these transplants, there are a lot of challenges that come up. So I'll just brisk you through the initial slide, which is about transplant. And I think the next thing has also been covered by both Sunil and Satyendra, which highlight the progress which has been made. Both this Pesaro group and Pescara group showing their experience of almost 900 patients and 125 patients with excellent survival, which dates back from 1981 till roughly around 2000. This is the transplant from EBMT database on thalassemia from close to 120 centers. But this is old data till 2006. So many transplants have happened, and a lot of unrelated donor and haploidentical transplants have also taken place thereafter. So what is the current status for transfusion-dependent thalassemia with the progress which has been made in the conditioning, IV busulfan, targeted blue levels? This all has been highlighted by Satyendra and Sunil. Coming up of drugs like thiatipa, triosulfan, fludarabine. So all these things have led to a significant change in the outcome of transfusion-dependent thalassemia. Okay.
Good. Boliye, sir.
Hello.
Climate is very comfortable.
Hello. So what changed in between? So basically, better patient selection and pre-transplant preparation, as very nicely highlighted by Dr. Sunil, that the pre-transplant preparation plays a very important role, especially in alternative donor settings, and maybe this has a role to play in match sibling and match related donor setting also. And we have a very small study based on this particular thing, which shows that the outcome of even unrelated donor transplants can be significantly improved by offering this pre-transplant preparatory strategy. Better understanding of transplant immunology, increasing donor options in the form of mud and haploidentical donors. So all this has led to significant change. But with this change, there are a lot of complications, and we'll just brisk through the complications. Sunil has already introduced the esteemed panelist with us today. So we will ask our queries from them. So this is the transplant timeline. And my understanding about the complications and where to place these complications, this is how I see it. So transplant during conditioning phase, transplant during immediate post-transplant phase, which is day 0 to day 27, post-transplant day 28 to 100, and thereafter. So this is how I try to divide the classifications and look at them. When we talk about classifications, we can also consider them based on the conditioning received, whether it is myeloablative, serotherapy, what kind of serotherapy, how intense, what dose, what are the patient characteristics. So transplanting a 5-year-old thalassemic is not same as transplanting a 15-year-old thalassemic. As Satyendra and Sunil have highlighted, match sibling donor, match related donor, and haploidentical donor all have different considerations and different things need to be kept in mind. GVHD prophylaxis strategy, and based on all these things, how well prepared we are for our transplant. So this is what decides the outcome of transplant in today's scenario. So we will go through this one by one. First of all, talking about the conditioning. So what is the preferred choice of conditioning chemotherapy for match sibling donor, and why? This question is for Dr. Yadav, sir. So in current scenario, I know Satyendra and Sunil have already discussed, but what will be your current choice of chemotherapy for match sibling donor setting?
Okay, thank you, Gaurav. So we don't have much time, so I'll try to be quick. So conventionally, busulfan cyclophosphamide has been used as a conditioning in thalassemia, but there is a problem in class 3 patients with higher mortality with this particular conditioning regimen with a higher risk of veno-occlusive disease. So nowadays, people have moved to triosulfan, thiotepa, and fludarabine-based regimen, which is much safer and has less risk of VOD, especially in class 3 patients. So my quick answer is that triosulfan-based conditioning is preferred conditioning these days, especially in class 3 patients. In very young patients, busulfan cyclophosphamide is still a good option. Thank you.
So thank you, sir. If Dr. Ruchira may allow me, I'll skip this question because of lack of time, because it has also been covered by Dr. Satyendra and Dr. Sunil about the previous conditionings. Now the dictum is very clear that if all the factors, I mean, the financial considerations are not there, the preferred choice is thiotepa, triosulfan, fludarabine. Graft failure and mixed chimerism are a significant concern with RTC. So what is are they a significant concern, or it was just a thought in the initial years and now it has changed? Dr. Hello, Dr. Shantanu, are you there?
Oh, hi, sorry. I might cut in and out a little bit, so apologies in advance for that. Thanks for inviting me. I won't switch on my video, but fantastic presentations from both the presenters. So, answering the question, is graft failure a concern? It definitely is still a concern when you're dealing with thalassemia. Slipping chimerism remains a huge concern, because if you think there are two things. If you're only talking about thalassemia, and we see that the chimerism is slipping, it's reducing as we see, we get seriously worried. Because if that happens, then we are kind of between the devil and the deep blue sea. What do you do about it? You reduce immunosuppression, but the main question that comes through is, would a transplanter be brave enough to think of doing a DLI? The problem is that if you do a DLI, you might be able to shore up your graft, but what you are buying also together with it is the chance that you might be pushing your patient into GVHD, and that's certainly something we take great pains to avoid. So in a nutshell, yes, we are worried about it. What can we do to avoid it? Better conditioning protocols and hopefully better anti-GVHD prophylaxis, and we hope for the best.
Right, right. So thank you, Dr. Shantanu. So graft failure, yes, it remains a concern, but as we learn more and more about transplants, how it works, the focus has now very clearly shifted from a myeloablative conditioning to reduced toxicity conditioning. There's a lot of focus on how well you prepare a patient, and this is what decides the outcomes. The graft failure in mixed chimerism have decreased significantly. As Sunil has highlighted, it is less than 5% even in haploidentical settings. In our cohort, in sicklers, it is almost zero in even in haploidentical transplants. So with the better understanding of transplants, these things have been taken care of in a great extent. And this is a paper which was published by the Italian group, or the initial results on the triosulfan based conditioning, and fantastic results, very nicely covered by Satyendra in his presentation. So I'll skip through this, but yes, reduced toxicity conditioning, or some, as they say, reduced intensity conditioning using thiotepa, triosulfan, fludarabine is the standard of care for a matched sibling donor thalassemia transplant nowadays. Moving on, TTF. So anticipated problems and your preparedness. So even considering this to be a reduced toxicity conditioning, still there are some problems. So what should we be watchful of while administering thiotepa, Dr. Ganesh?
So basically, thiotepa, because of its very good favorable toxicity profile and better immunosuppressive as well as myelosuppressive properties, It's being used quite commonly in combination with the myeloablative or reduced intensity, reduced toxicity conditionings. So the most important thing is it's because of its skin toxicity. The administration should be 0.5 to 1 mg per ml. The dose is less than 200 mg. It can be given in 250 200 ml NS, or the dose is more than 200, so it should be given 500 ml NS, or if the dose is more than 500, should be given in 1 liter. And the reconstituted solution can be used up to 24 hours. So the dose is 5 mg per kg, either 12 hourly or on 2 consecutive days. And the patient should be asked to take bath twice daily, at least 48 hours after the thiotepa administration. Of course, the even though thiotepa is a bi-alkylating agent, the administration has not shown much higher incidence of veno-occlusive disease across the various malignant as well as non-malignant indications. But the appropriate precautions should be administered.
Yeah, so thank you, Dr. Ganesh, and your background is as learned as you are. So very nice background, lot of books there. What complications to look for while administering triosulfan, especially in younger kids, Dr. Anupam?
Yeah, thanks, Dr. Gaurav. So this session started with a question: what is the best regimen? And I think we all understand that triosulfan is the drug which has changed our thalassemia transplant outcome. So one should be very careful in terms when we are using triosulfan in terms of immediate complications, and the late complications should also be kept in mind. So like skin rash, exfoliation, and sometime you will get a complication like alveolitis after some time, and a very long-term complications. Some patient develops pulmonary fibrosis as well with triosulfan, and some side effects like which was documented with busulfan, like veno-occlusive disease is also happens with triosulfan, and some long-term side effect like cardiomyopathy. So though this drug has changed our thinking in terms of outcome, but we should not be relaxing while administering this drug, and we should be watchful for the immediate and long-term complication for this drug.
So yeah, thank you, Dr. Anupam. So main things to look for is like, yes, the incidence of sinusoidal obstruction syndrome, BOD, is less, but yes, we cannot completely ignore it, especially in kids who are younger. Sinusoidal obstruction syndrome, there is a similar kind of thing which happens in the lungs also, which is called as pulmonary BOD, although rare, but whenever it happens, it is very significant. We have seen it in two of our patients, not thalassemia, but other inherited marrow failure states, and it is really a challenging scenario. And CNS toxicity, where the kids are predisposed for seizures when they receive triosulfan. So these are the things which we need to look for. Any comments on or personal experience about fludrobeam toxicity, Dr. Ruchira?
Dr. Gaurav, I personally haven't had any experience of toxicity to fludarabine with our cohort of patients that we've treated with fludarabine. But yes, people do talk about CNS toxicity, which needs to be watched for in these patients. Some of times it may be presenting as confusions, hallucinations, or even coma in these patients. But personally, haven't had an experience.
Very true. It's a rare complication, fludarabine related neurotoxicity, but whenever it happens, the dictum is that you should not re-challenge that patient for a second course. So fludarabine is in use for pre-transplant immunosuppression, and then during the conditioning for alternative donor transplant. But if there is a single episode of CNS neurotoxicity with fludarabine, then a second challenge should not be given. Okay, because it is the second, you might not get a second chance that with fludarabine related CNS toxicity. So moving on to alternative donors, again, this has been covered partly by Satinder and Sunil. What you would like to do? Would you like to do anything differently in cases of matched unrelated donor with peripheral blood as source, Dr. Shantanu? this conditioning is fine. I'm specially focusing on the serotherapy. Anything different or any different pre-transplant preparation whenever you have, because majority of our donors, whenever they get an unrelated donor for our patients, majority of times, as we see, we get a peripheral blood as a source. So would you do something differently, Dr. Shantanu? I think he's not there.
Sorry, I missed the question. Can you just repeat that?
Dr. Shantanu, if you have a matched unrelated donor with peripheral blood as a source, unrelated donor we are talking about, would you like to make any changes in your conditioning strategy or your serotherapy?
Okay, so basically, if you are using a peripheral blood, what we obviously have, we have more mature cells that are coming in compared to if you were to use a marrow as a donor, which means, and this is something we know, that whenever you're doing a transplant with a peripheral blood as a source, your chances of your rates of getting GVHD would be slightly higher. So in which case, these are the cases which would benefit from using serotherapy, whether you use ATG or CAMPAT, something to actually take off some of the T lymphocytes. So that would be the main change in protocol that needs to be done compared to peripheral blood as compared to marrow when you're doing a mud.
Sure.
Just Gaurav, just a comment there, because we've got a lot of students also logged in. Is that there is something, a concept of proximal and distal ATG. Proximal is very away from the graft, whatever kind of definitions you make, and the ATG closer to the graft. So in a PBSC graft, we'll try to make ATG closer to the graft so that there's residual activity against the donor mature T lymphocytes. And a marrow graft is a little bit more proximal to take care of the rejection, not for the GVHD. So that may be a little bit alteration we'll do in the conditioning.
Other thing which might be considered is changing the serotherapy from so CAMPAT is a challenging drug. It is not available and it comes with a lot of viral reactivations. If we have to choose with the ATG, then we might consider using rabbit ATG in this setting, because the chances of graft versus host disease, which will be a concern with mud donors, especially with peripheral blood as a source, might be a little bit less. All right. So this is about the mud donor setting. What complications are expected if we are dealing with a haploidentical donor? Sunil has highlighted it. Graft failure was a significant problem, which has been addressed very nicely by using pre-transplant immunosuppression. Anything else, Dr. Yadav, sir?
So haplotransplant in particular, when we are doing, so as you have highlighted, that graft rejection or poor graft function can be one of the big problems. But other than that, there can be hemorrhagic cystitis, which we commonly see in other haplo settings also. And BK virus reactivation is a common problem which we should be prepared for. There is something known as engraftment syndrome, so that we have to look out for. And there is around day 14, 15, other than the engraftment syndrome, if the child has gram-negative sepsis, it becomes a dual problem, with engraftment syndrome causing capillary leak and gram-negative sepsis also causing capillary leak, and these patients go in shock and land up in ICU. So prevention of infection and early management of sepsis is important. And then comes your the usual risk of acute graft versus host disease and chronic graft versus host disease in haplo. That's also very much a risk. And VOD is a risk in thalassemia, even in haplo PTCY. So you have to watch out for that. And thrombotic microangiopathy is another real problem that we have to watch out for. Thank you.
Yeah, thank you, sir. Thank you. This last question is not that relevant, because I doubt how many cord blood transplants are done nowadays, but just for the sake of completion of alternative donors, what is your take on related cord blood transplants for thalassemia major in Indian scenario, Dr. Ruchira?
So cord blood transplants are definitely taking a second place in the Indian context. What we are worried about cord blood transplants is the long time they take for engraftment. So prolonged hospitalizations is the biggest challenge that we face with these patients. Though there is a theoretically decreased risk of GVHD in our cord blood transplant patients. With related cord blood transplants, I personally would rather wait till the donor is a little older and then can donate fresh stem cells to us rather than using a cord blood unit. One, because the number of cells that we get, stem cells that we get with cord blood is always doubtful, considering that the cryopreservation may or may not be up to standard. So that is my take on that.
True.
Yeah.
So I totally agree with you, Dr. Ruchira. So things are different in this part of the world as compared to the European and American scenario. So there, the Locatelli and group very beautifully demonstrated that the outcome of related cord blood transplant is as good as matched sibling donor transplant, but somehow we have not been able to reciprocate this. And for our for Indian scenario, somehow cord blood taking is sort of going down, and haploidentical transplant.
Gaurav, can I just add a comment on this?
Yes, sir.
So,
yes, sir.
In India, because of our cord blood banking, that's the big issue, that we are not sure that after thawing will we get enough stem cells or not, and that's why we prefer to do a combined transplant with the peripheral blood or bone marrow and cord. And we have done 5 such cases, and the good thing was that there was hardly any GVHD. So chronic GVHD was much less in these patients. So adding cord blood possibly reduces GVHD. That's what I would say. Thank you.
Yes, sir. Yes, sir. So a top-up transplant.
So Gaurav, no. So there is
combination transplant is. Yes,
so
yes, Satya.
There is a very significant significant paper just 1.5 years ago from USA. There is a combined transplant from cord with haplo in thalassemics, and they have produced 100% survival. So it's just the how do you do, and the GVH and everything, and Grafton was taken care by the cord and everything. So they have it their own way. So how do you expand the cord? How good your banks are? Ultimately, that is the game, because the engraftment they have sorted out by the combination and all that. So cord is rolled out. That's a difficult thing for us, primarily because of our infrastructure. But cord is there, and probably one day we will also be using it.
Okay, thank you, Dr. Satyendra. Moving on to serotherapy, so which is a very important aspect. First of all, I would ask Dr. Yadav that do you what will be your preferred choice? So if you have an option with along with thiotepa, treosulfan, fludarabine, would you be comfortable adding ATG in a matched sibling donor setting or not? So this is a big question, because many people just go with TTF without using ATG for for matched sibling donor thalassemia transplant as well. So I would like to have your take on that.
Gaurav. My quick answer is that I always prefer to use ATG in thalassemia transplants along with them, even in matched sibling conditioning, and that reduces the risk of rejection as well as it reduces the risk of chronic GVHD, which both we don't want. Thank you.
Yeah. So it is clear that ATG should be used even if it is a matched sibling or a match-related donor transplant. Preferred serotherapy for matched sibling donor, Dr. Ganesh?
So, first of all, I should confess my experience for match unrelated or alternative donor transplants for thalassemia major is almost zero. So whatever I I had gained the whatever little that is through all of you the experts in thalassemia alternative donor transplants across the country, Dr. Satya Yadav sir, Satyendra Katewa, Sunil Bhatt, and Gaurav Kharya. So with regard to matched sibling donor transplants, with the advent of this novel conditioning with treosulfan, thiotepa, particularly thiotepa having the equal immunosuppressive as well as myeloablative potential with reduced toxicity, the role of serotherapy across the literature is not very well focused. But in our scenario, where most of our patients are class 2, class 3, as Satya sir has highly nicely elaborated, for these patients, both in terms of decreasing the graft rejection as well as the decrease in the incidence of GVHD, with particularly with the peripheral blood as a stem cell graft source. Given the choice, I will prefer ATG despite TTF as a conditioning regimen, and also this becomes more valid for unrelated donor transplants, because there the incidence of the GVHD as well as graft rejection is quite significantly higher compared to matched sibling donor transplants.
Thank you, Dr. Ganesh, for answering both the match-related and match-unrelated donor scenarios. Dr. Yadav says, so what will be your preferred serotherapy in haploidentical transplant settings for thalassemia major?
So yes, for haplo PTCY approach, I prefer to give a low dose ATG, 4.5 milligram per kg of rabbit ATG, and we tend to use it little distal from the like day -8, day -7, day -6, something like that. But there is some interesting data in leukemia where they're using it proximal, and in a couple of patients we have used it proximal also, especially in class 3 patients where the CRS was taken care of. The patient didn't have much of CRS, but both did get GVHD later on. So the data is still not there to recommend the right place and right timing of ATG, but it should be given in haplo PTCY, preferably little distal at this point of time and low dose.
Thank you, sir. Thank you. Now moving on to early post-transplant complications. This is a, I'm just covering the...
Gaurav, we have about 5 minutes to conclude.
Sure.
We just take the important questions and to the point.
Yeah, so I'll just be going through these important complications which have come up. So this is one important group of complications which have come up, early endothelial complications. So what are these complications and why have they gained so much of attention, Dr. Santanu? Dr. Santanu is not there, probably. Dr. Ruchira, would you like to take this?
So the endothelial complications that we see, like sir mentioned, was capillary leak syndrome that we often encounter around the time of engraftment. We see engraftment syndrome happening. We see peri-engraftment syndrome happening. We are very worried about veno-occlusive disease, especially of the liver, especially in our thalassemics and the ones that are class 3, because they often have iron overload and they may not be, so they tend to have more incidence of VOD in these patients. We've seen a higher incidence of press in our setting, which is also again endothelial damage leading to seizures and comes in because of the calcineurin inhibitors that we have, plus the endothelial injury that is already happening in our patients as well. So these are the few that we have come across.
Yeah. So yeah, thank you, Dr. Ruchira. So these are the set of these are the group of disorders which come under this broad category: sinusoidal obstruction syndrome, formerly called as VOD, capillary leak syndrome, engraftment, peri-engraftment syndrome, diffuse alveolar hemorrhage, thrombotic microangiopathy, and posterior reversible encephalopathy. Now, VOD. So I mean, it has already been covered with the use of triosulfan, with the use of IV busulfan. Whenever the busulfan is being used, the incidence of VOD has significantly come down, and it also depends on how better we have prepared our patients. So I'll just skip this question. How would you look at sinusoidal obstruction syndrome in kids, Dr. Ganesh? Are the criteria different as compared to the adults?
So there is a EBMT criteria for VOD for pediatric population, which is not very different from the previously described Seattle as well as Baltimore criteria. But yes, based on this, one important parameter apart from the conventional hyperbilirubinemia, weight gain, hepatomegaly, ascites. In the EBMT pediatric criteria, going by the Baltimore or Seattle criteria, about some proportion of the pediatric population could not fulfill the criteria and were classical VOD, subsequently proved. So unexplained consumptive or transfusion refractory thrombocytopenia is a criteria which is included in the EBMT criteria. So probably that is one aspect which is different from the adult population.
Yeah. So these are the criteria. This is given by Selim and group. No limitation of time. This is first and most important thing. The classical thing starting from day -5 till day +35. That is not there. We have seen patients having at day 40, 45, 50 also developing features of VOD. The presence of 2 or more of the following: unexplained consumptive transfusion refractory thrombocytopenia, unexplained weight gain, hepatomegaly, probably better confirmed by imaging, ascites, and rising bilirubin. So these are the revised criteria, and based on these revised criteria, this was a nice review in EBMT in May 2020 that using these criteria, there was a significant reduction in the morbidity and mortality and overall the cost also when these revised criteria were used rather than the previous criteria. Moving on to another important complication which has gained attention recently. So we all are aware about the engraftment syndrome, the classical, the definition of engraftment syndrome, but this peri-engraftment syndrome is something which has come up recently, especially in alternative donor settings. So what is peri-engraftment syndrome, Dr. Anupam?
So basically, peri-engraftment syndrome, as per the name suggests, before the engraftment, the sign and symptoms like an engraftment happens, like fever, rash, and mild weight gain. So that comes under the criteria for diagnosing a peri-engraftment. And generally, we see, yes, in the haploidentical transplant, it is quite frequent. So, but in matched sibling transplant, also we see around 10 to 20% of the cases with this peri-engraftment syndrome-like symptoms.
True. So any association with conditioning or transplant setting, Dr. Shantanu? I think Dr. Shantanu is not there. So basically, we'll just go through this peri-engraftment syndrome. It is a syndrome which is like engraftment as described by Dr. Anupam. And the main differences with engraftment syndrome are development in context of malleability conditioning or reduced intensity conditioning, LOH, HSCT, earlier presentation. So the presentation is earlier as compared to the engraftment syndrome. Okay, the fluid retention is seen in almost 30% of the cases. Important thing is whenever the patient develops pre-engraftment or peri-engraftment syndrome, there is less likelihood of graft failure, but the chances of having graft versus host disease is high as compared to the other patients who do not develop it. Moving on to another very important, I think this is a thing which we are seeing more and more often, which is transplant associated TMA, so microangiopathy. What is TMA, Dr. Ruchira?
Transplant associated microangiopathy is generally considered to be a triad of symptoms, which is manifested by hypertension, thrombocytopenia, which may be refractory as well, and you also get an elevated LDH, and there is breakdown of these cells happening. This could be related to a number of factors that may be associated, most commonly being the conditioning therapy, the underlying disease that you're treating for, and even the calcineurin inhibitors that we use as our post-transplant GVHD prophylaxis. On symptoms, we also, when I've asked for a peripheral smear, we often see schistocytes, which helps to confirm the diagnosis of TMA in our patients that we see this.
So thank you, Dr. Ruchira. Dr. Yadav, sir, you have a pretty wide experience of matched sibling donor, alternative donor, and various immunosuppressive agents also, which were available initially, and the newer ones which have come up. So, based on your personal experience, any thought about one immunosuppressive agent is better over other when it comes to TMA setting?
So traditionally we have used cyclosporin. That's the commonly most wide experience we have is with cyclosporin in matched sibling and even in mud transplants. But now we have switched to PTCY with tacrolimus and MMF. So in both, hasn't been a huge difference, but somehow there is an option of sirolimus also, and we have found that if we are using sirolimus with MMF, the overall complications are less as compared to with tacrolimus or with cyclosporin. But this is just maybe a bias. I'm not sure that we haven't analyzed the data in a bigger, more detailed way. So I can't really comment. I think they all are equal, but sirolimus may have less complications possibly.
So yeah, sir, I do agree, because we also have the same kind of experience, and for past 3 years or 4 years, we have completely moved to sirolimus, and the complication rate, especially the TMA, has come down significantly. So TMA, I'll not go much into it. This all is available in the EBMT textbook, which we all have on our desktop. So we can go and just bridge through this particular complication, which is
Gaurav,
very,
we
very
need to wind
important
up
to know.
now, please.
Yeah. So patient-related factors, late HSCT complications. So transplant, especially for diseases like thalassemia, doesn't end with the day 28 or day 100. I mean, these patients need to be followed up on a long-term basis for other post-transplant long-term complications, the organ dysfunction. So this is what we need to be careful about. Regular follow-up is required for these patients. So we'll move on. And I think with this, I would like to thank you all. Thank you, all the panelists, for your inputs pertaining to the burning issues which we often face while managing these patients with thalassemia major. So thank you all. And
Thank you, Gaurav.
Thank you,
Yeah.
Gaurav, for your
Any
effort.
questions,
And I'm
Sunil? Would
sorry
you like
to cut
to
you
take?
short because it's a long topic, and I think we should.
I know,
it wasn't
I know,
enough
I know,
time.
I know.
We'll have to catch up
Sunil,
again with transplant and thalassemia, I think.
so any questions which are there in that text box?
So I think we have
I've
sorted
answered
out
the
all of them,
questions.
except for
Everything
one.
okay.
I think there was a question on fertility preservation. So if someone wants to take that, so Ruchira, I want to take one on fertility preservation and fertility.
Yes, a lot of there's a lot of data coming in. There is an incidence, a higher incidence of hypogonadism in patients who have undergone transplant for thalassemia.
Yeah.
But what we have also found that there is females who've undergone transplant still have the childbearing potential, and there are case reports coming in where these women have had babies after transplant as well. So the case is not all lost. We still have hope, and we are hoping that more and more people will report this, and we'll have fertility coming up in the future as well. So
I think I agree, and with the treosulfan thiopurine conditioning, we don't have enough long-term data. There is some potential, and there was a very elegant study from
treosulfan is supposed to be more protective towards your fertility.
So this was about the conditioning, but what is your strategy on fertility preservation? So especially when you have sort of teenage kids who are undergoing transplant. So do you offer it routinely?
So all our males that come in, Gaurav, who are adolescent and have started masturbation, we would definitely talk to them about sperm preservation. It's a very delicate topic to talk about, but I think over the years we've realized that we need to talk about it.
Exactly.
The younger ones, using testicular biopsies and trying to offer them some kind of cryopreservation techniques, we are not offering those at the moment at all. For the females, again, if they are post-pubertal, the option is put there to have an oocyte preservation done, but not a single patient has actually opted for it till now. And since we don't do adults, I really can't talk about embryo preservations at all.
So thank you very much. I think that covers the spectrum, and I should thank Gaurav and the whole esteemed panel. It's been really interactive and learning experience for all of us. But I really think that this time is not enough. I think we'll have to meet again. So I take opportunity to thank the CELON labs also, who have kindly provides platform to all of us.